workshops nationwide in clinical training um, and education, and mobilizes our network to advocate for more just and equitable sexual and reproductive health care. Um, Repro TLC improves access to comprehensive and reproductive health care, and we train providers in abortion, miscarriage care, contraception, pregnancy options counseling, and more. And we really envision a world where everyone has access to high quality patient care. And that's why I'm so excited about this interpretation of best practices workshop to try our best to alleviate language barriers in healthcare. So this is through our provider and community education program. Feel free to scan this QR code. It'll also be sent in an after email, but we host monthly workshops. We do a twice a year abortion doula training. It's 4 weeks. You'll be trained in abortion doula care. We also do a non-scalpel vasectomy workshop where you get shipped kits and you can do it with a facilitator. We do workshops in supporting interpersonal violence survivors in their routine reproductive health care, along with reproductive justice advocacy trainings and anti-racism in healthcare. So feel free to scan and see what upcoming workshops we have. We'll have registration dropping on our social media in a week or two for our May workshops. Before I lead us in a land acknowledgement, feel free to show up how you want today, whether that's camera on, camera off, coming off mute, not coming off mute. We understand you're taking time out of your afternoon or night to be here. So we understand you may have caretaking activities and things like that that you may have to do. So feel free to just show up however you can. After there'll be a survey and you can receive a certificate emailed to you from Repro TLC. So I'm going to go ahead and lead us into our land acknowledgement, and Joe will go ahead and drop some resources for you to find out what native land you're on, along with a bias test that we use and calculating your voluntary land taxes. So it is our collective responsibility to acknowledge that Repro TLC was founded on the stolen land. And we recognize not only the historical stewardship of these lands, but also the ongoing efforts of Indigenous communities to protect and sustain them. The impacts of colonization continue to affect Indigenous peoples, especially Indigenous women, Two-Spirit, and gender diverse individuals who face systemic barriers to health and safety. We honor the resilience of Indigenous communities and stand in solidarity with their ongoing efforts to reclaim land, life, and culture. In recognizing the injustices of the past and present, we commit to supporting Indigenous sovereignty and advancing reproductive justice for all. I'm going to go ahead and turn it over to our amazing facilitator tonight, Pamela. They will go ahead and introduce themselves. If you need any tech support or anything, feel free to message me privately in the chat or Joe privately in a chat for any tech support. And I'll go ahead and turn it over to Pamela.
Hi everyone, my name is Pamela and I use they and them pronouns. I am a member of the Repro TLC Speaker Bureau, and I also have experience coordinating logistical support for people seeking abortion care, emotional support, and financial resources all over the US. I have trained advocates and medical professionals on sexual assault crisis intervention and best practices for supporting clients seeking abortion access. Currently, I am a bilingual options counselor with All Options, which is a talk line for anybody on the pregnancy spectrum. And I'm also a service provider with the Miscarriage and Abortion Hotline. And I want to do some quick intros. If folks can drop this in the chat, if you want to drop your name, if you want to share your pronouns and your city, and also what is your energy level as you enter this workshop, and if there's anything you hope to take away from today's workshop. Cool. All right. So this is our agenda. We are going to be going through some history of medical interpretation in the United States, the terms that we're going to be using, why focusing on diverse patients is important, barriers to provider-patient communication and the impacts of that, common causes of adverse events, high-risk patient safety scenarios. We're going to do some breakout rooms. There's also going to be some breaks in there. And then we're going to go over recommendations, best practices, how to implement a systemic approach, and how to address preventable medical errors. So a little bit about the history of medical interpretation and it started very informally. It was basically with family, friends, community members, translating or interpreting for people. And it was seen as like a benevolent act that was given freely by community members and not something that was like required or expected to be part of the medical encounter. And it was until the 1960s, so after that, that there started to be more research on the impact of medical interpretation on medical encounters. And after that, the government started to get involved as well. And with Title VI of the Civil Rights Act of 1964, that prohibits discrimination based on national origin and requires language access in federally funded healthcare settings. As time went on, more studies were published, practical manuals, as well as books and articles. And in the salaried professional positions and formal training. In the 90s, colleges and universities started to create certificate programs for medical interpreters, and professional organizations started to standardize interpretation practices. In 2010, the Affordable Care Act strengthened language access requirements. And generally speaking, in very broad strokes, we also have national standards and accreditation standards for patient safety. And some of those are that hospitals will provide cultural diversity trainings to staff based on their duties, offer language access services at no cost. Hospitals will inform patients of language access services verbally and in writing, and they will ensure competency of language service providers. And some of the terms we'll be using are patients who speak languages other than English, and patients with limited English proficiency. I'm using these interchangeably as a way to emphasize that a limited understanding of English has an impact, while also using other language that does not center deficit-oriented language perspectives. And if you have any questions throughout the presentation, you feel free to drop it in the chat at any time. Language justice is generally defined as access to information and the right to communicate, understand, and to be understood in your primary or preferred languages. Language justice is an ongoing and ever-changing practice of supporting equitable communication. So that means it's going to shift depending on your region and who is needing language justice. And linguicism. So linguicism is a form of structural oppression based on language. The results are structural advantages for those who speak the dominant language and structural disadvantages for those who speak non-dominant languages or have a limited proficiency in the dominant language. And just curious if folks have witnessed or experienced linguicism in their line of work, if you want to drop that in the chat. Just a yes or no, just to kind of see if folks have heard of this before, have experienced it before. Some examples of linguicism are in many school districts, there's bilingual education initiatives that do not teach students to read and write in languages other than English. This reduces their literacy to speaking only for those languages other than English. Also, over 90% of scientific articles are published in English, so that's going to have an impact on public health. One example of that is patients with a preference to languages other than English experience delays in receiving their first COVID-19 vaccine dose and were twice as likely to be hospitalized or die from COVID. Patients with language barriers also report lower rates of gynecological cancer screening, higher rates of unscheduled cesarean births, and forced sterilization. And neighborhoods with higher rates of linguistically isolated households are associated with higher rates of mortality and depressive symptoms. And linguistically isolated households depend on the English-speaking ability of all adults in the household, according to the census. So anybody 14 or older is considered an adult, and a household is linguistically isolated if all the adults speak a language other than English and none of them speak English very well. And why is it important to focus on diverse patients? Well, 20% of the US population speaks a language other than English, and 8.6% of the US population has limited English proficiency. So within that 8.6% is where folks with isolated households are found. And research shows that patients who primarily spoke languages other than English reported poor quality of care, such as decreased use of preventative services, inadequate performance of pain management in emergency departments, longer emergency department stays, and more diagnostic services, and were less likely to receive referrals for follow-up appointments. They also experienced surgical delays, readmission, difficulty managing their condition, and difficulty understanding follow-up, preparation for procedures, and recognizing symptoms that prompt additional hospital visits. Quality of care and patient safety informs cost of medical care. Research shows there were longer hospital stays for patients who spoke languages other than English, when professional interpreters were not used at admission or at discharge. For patients with limited English proficiency, longer hospital stays resulted in an increased risk of line infections, surgical infections, falls, pressure ulcers when compared to English-speaking patients with the same condition. Do folks have any thoughts on what is causing these issues? Like, what is a theme that you're seeing here, if any? So some of what we see is communication causing these issues. So barriers to provider-patient communication lead to poorer health outcomes. Effective communication is crucial for establishing trust with patients. It can improve adherence to treatment and overall patient satisfaction. Language barriers can create feelings of fear, distrust, misunderstanding, and lack of confidence in the healthcare system. Patients who have limited English proficiency are at higher risk of experiencing adverse events when accessing medical care. These adverse events are more likely to lead to serious harm than adverse events impacting English-speaking patients. Effective patient-provider communication is also important for patients with limited health literacy or patients with disabilities. And effective communication between patients and providers is vital in mitigating medical errors. Okay, so
I'm gonna go ahead and list off some comments in the chat because I feel like they're really good, and I know you probably can't see the chat right now. But we had some people say that perceived time barriers, perceived quality of interpreter, limited time to spend with patients is a big one. I feel that as well. toward English as a dominant language. Also, people assuming folks who don't speak English are less intelligent. Xenophobia, not knowing terminology to accurately describe symptoms. Overworked and understaffed, and takes time to use language line. That's an important one. Um, People brought up bias, fear of change, financial oh my God, I can't pronounce that. But patients feeling stigma, so not asking for an interpreter when needed. I don't know if you want to address any of those or look through the chat.
Yeah, I mean, those are definitely all true and make sense. I think that one of the things that we're going to go over is that it's really important for there to be institutional support and support from the people working within these medical contexts in order for a change to work. It has to be embraced by everyone involved, and it has to be very active, and there has to be also like strategic planning and funding that goes to that. So there's definitely it is difficult. Sometimes there might not be the resources that are needed, or sometimes, like someone said, they take long to answer the interpretation lines. And some of these recommendations that we're going to go over can be applied if your institution is trying to move forward towards language justice. But there's also others that could potentially be implemented as able to move forward in that direction. But ultimately, I think like when we were going over the history, there is a part that said that it started informally, and I know that a lot of the times it is informally practiced today, like with significant others translating, but we're going to go over why that might be harmful, and that way we can at least use information that we have to operate in present contexts. So research-based common causes of adverse events. Undesirable medical outcomes. Medical providers. So one thing that leads to this is when medical providers request that significant others interpret. This basically compromises confidentiality and informed consent for the patient. This may impact the patient's ability to disclose critical information. For example, if a parent is translating for their child or vice versa. It also takes agency from the patient. Untrained interpreters may not understand medical terminology, and untrained interpreters may not understand the nuances and impact of culture, language, gender, and race on the interaction. And research shows that untrained significant others and untrained staff are more likely to make significant medical errors in comparison to trained interpreters. Another common cause of adverse events, and this is specifically for people who speak languages other than English, is when a medical provider themselves uses basic skills to get by when working with diverse patients. And so using diverse skills, even by a medical professional, increases patient risk. Also, cultural and religious competence can impact patient care. Medical encounters are influenced by cultural beliefs, such as certain gender roles, deference to authority figures, dismissing pain, and historical experiences with the dominant culture in and outside of the medical context. And so here are some high-risk patient scenarios. So these are basically times when a flag could go up for you to be like, oh, this is a high-risk situation, and we can apply. Those are the moments that we really want to apply these tools that we're learning. So When obtaining informed consent, it's important to ensure that the patient is informed and can fully participate in their own medical decision-making. It's important to ensure that the patient understands uncertainty, risks, treatment choice, and how treatment may affect their health and well-being. It's important to obtain informed consent for diagnostic procedures, therapeutic procedures, emergent surgery, elective surgery, and gathering medical history accurately and completely. And it's also important that to assess patient comprehension of diagnosis, treatment plans, and discharge instructions, as well as proper use of medication. And so communication is going to be crucial for these things to happen. Other high-risk patient safety scenarios are surgical care. So just how to prepare for that, when to begin fasting, how to alter medications if needed, working with anesthesiologists, allergic reactions, also preparing for tests and procedures is another high-risk patient safety scenario. When treatment complications arise, and emergency department care and follow-up care. Okay, so I'm just gonna say this question and feel free to answer in the chat. I'll keep moving through, but if there's any answers, please let me know so we can hear what folks have to say. So we're gonna go over some case examples in the next slide, and the question that I have is, what are some high-risk patient scenarios you see in these case examples? And if you're able to look at the PDF file that was given, it's questions and recommendations sheet. If you go to page 2 or 3, it will have the questions and the high-risk scenarios if you want to look at those to help you answer the questions. And so some of them are, these are real-life case examples of patient safety reports, and these are reports where delays were caused. And just as a reminder, for patients with limited English proficiency, longer hospital stays resulted in an increased risk of line infections, surgical infections, falls, pressure ulcers, when compared to English-speaking patients with the same condition. So the first one is, the patient arrived in hemodialysis unit to do stat, no identification wristband, and could not verify because they didn't speak English. So some of the high-risk situations here are informed consent for diagnostic procedures, patient comprehension of treatment, and obtaining a full medical history. So those were instances where those gaps were not met, and so it ended up causing a delay for this patient. And as we know, delays for people who speak languages other than English can lead to more serious outcomes and adverse outcomes. Are there any responses in the chat so far?
Or feel free to come off mute if it's too much to type.
Okay, I'm gonna go to the next one. So the next one is, patient did not have a stress test because a Spanish interpreter was not available. This delayed discharge at least 24 hours. And so for this one, some of the high-risk scenarios were comprehension of discharge instructions and obtaining informed consent for diagnostic procedures.
Oh, I think
And
there
the
was an
third,
answer to the first
ahead.
one. Oh, sorry. Blair said once we couldn't find an interpreter, For a patient after her delivery for 4 days, she had a major complication that we could not discuss. So that's from a comment in the chat.
Yeah, and so, that's extending the patient's discharge date, like this one, like scenario 2. It delays when they can be discharged, which puts them at a higher risk for adverse events. And the last one is new patient arrived in infusion unit for first IP Taxol appointment without orders, consent, or a recent physician's note. The patient did not speak English, interpreter and MD called, delay in treatment resulted. And the high-risk scenarios that I found here were informed consent and comprehension of discharge instructions and follow-up care. And for the most part, the one that I see coming up a lot is informed consent, which is really important for the patient to be able to have an active role in their healthcare decisions. Yeah, so if that document, if you go to page 1 and 2, you'll see it'll lead you right to where these questions are and the case examples as well. So some of the questions that we're going to be looking at are, what are some common causes of adverse events and high-risk patient scenario? So what we just went over, basically just trying to identify those. And I will start reading the medical. So these are medical errors. So the first one is patient is Ethiopian speaking. On multiple occasions, there had been a failure to provide an interpreter. She has been using family members to translate, and they are not always available. This is unacceptable as we have had issues with medications, which one to take and when. I believe her worsening diabetes is a direct result of my inability to have effective clinical meetings with her. So I'll give a couple, like a minute for folks to want to look at the high risk scenarios and common adverse events and just drop some answers that you see. So one right off the bat that I see is the doctor allowing the family members to translate. We know that that automatically leads to a higher risk of adverse events for patients. And for high risk scenarios, I'm seeing high treatment complications, informed consent, follow-up, and understanding risks of taking medications properly. So these are all things that
Sorry, I'm just gonna pause you right quick. So we have some people in the chat. I know you can't see the chat right now. So Blair said proper use of medication. Kelly said subpar medical care, no access to education regarding disease, plan of care. And some people have commented that are we answering for number 4 only or all of them? I think there was an echo, so a little bit got cut off. So what number specifically are we on right now?
we were just on number 4, so I'm going to switch over to number 5.
And then we have another comment about patient unable to share personal barriers. And these are regarding number 4. If there's anything else people want to comment before we move on to 5, we can give it 30 seconds in case anybody was unsure what question we were answering.
And thanks so much to the folks participating. I know that this is, it's a lot of information. A lot of it is like repeated, but it is a lot of different information. So I appreciate you looking at the scenarios. I'm going to move to number 5. I'm going to read that and feel free to drop your answers. So high risk scenarios and adverse events. Patient came down with his mother for a cube film. Most exams that are automatically scheduled are chest exams, so I performed one in error. Usually, I verify the exam with the patient, but he was 11 years old and his mother couldn't speak English. Immediately after I realized I'd had done the wrong exam, I called the doctor and had him reorder the exam, and I performed the correct one. Feel free to also come off mute.
There's a few comments. Efficiency of clinical meetings is so real for people with complex situations. Number five, increased exposure to radiation without clinical value. Um, and then somebody yes that, and then we have delay in care seems to be running theme for all of them. And then confidentiality is not problematic when family members have to be translators. This is regarding the last one. And then unnecessary testing, waste of HC resources, risk of harm increases with the number of X-ray exams. If you want to um, talk about any of those.
Yeah. Yeah, so somebody mentioned using resources that don't need to be used, and that's something that is going to impact the cost of medical care. Also allowing it sounds like they didn't allow the mother to interpret because she doesn't speak English, but it also sounds like they would have if she did speak English. I think also cultural and religious competence there. Informed consent, which is one that keeps coming up over and over. If you can't communicate with the patient, then how is informed consent going to be obtained? I'm going to move into number 6. Informed consent obtained with no Spanish interpreter in emergency room. Patient did not understand the procedure when asked by interpreter.
So that's not informed consent.
Yeah, exactly. Not informed consent. And beyond that, the patient is not understanding the procedure, is not understanding the treatment plan. Yeah, so the high-risk scenarios that we were going over talk about situations where a patient will be that are high risk for adverse events. So basically, the answer that I was looking for is emergency room. So when someone who speaks languages other than English is in an emergency room situation, their risk for adverse events goes up.
Hi. Um, I think that's true for emergency room. I'm a provider and I've worked in trauma and emergency. And I think also I see this happen in abortion clinics when
Mhm.
there's an emergency happening, right? And so if there's like a hemorrhage or if there's some type of fear. And so I think it's not just in like these acute care settings where I think hospitals are actually more better prepared to deal with language uh limited English language folks or patients more than at abortion clinics and I've seen better responses. So sometimes I think this does happen in like smaller clinics too.
Thank you. Thank you so much for sharing that. Yeah, definitely. And that's going to impact access to reproductive care for the patient and their experience with having agency when accessing an abortion, for example. All right, I'm gonna, oh, sorry, go ahead.
Sorry. I wanted to say that I think that sometimes these are situations where there's this perceived urgency. And so the idea is that we're going to save time by not using an interpreter. And then what it ultimately does is that it ends up causing these downstream effects that actually cause delays and inadvertent like need to continue to use time in ways that are actually not efficient. And so I think that the sense of perceived urgency needs to be addressed in these systems.
Yes, definitely. And also, I think the cultural competency and people's understanding of what not having an interpreter actually does. Because there's some research that shows that um, doctors can underestimate when a person doesn't understand what they're telling them when a patient doesn't understand what they're being told. All right, I'm going to read number 7. Patient was just admitted to the step-down unit from the medical intensive care unit and was reported to be OO times 3, awake and alert, but Greek speaking primarily. Patient was found on the floor, cardiac monitor attached, Foley still attached to the bed. Patient gestured she was going to the bathroom unassisted. So what is something that there was like a disconnect here?
Somebody said in the chat, it sounds like she wasn't communicated with and she didn't know how or if staff were there for her.
Yeah, didn't know, couldn't probably speak to staff because of the language barrier, and also didn't have comprehension of the treatment plan. So that also makes me think what about informed consent? Any other stuff in the chat or folks who want to say something before I move to number 8?
I just wanted to say that I could definitely see this kind of thing happening on our labor and delivery unit, because when patients call out, it connects them to a phone at the nurse's station. But a lot of times you answer and the patient doesn't say anything because English is not their primary language. And people will just like hang up and assume that they called on accident, when in reality the patient really needs somebody, but they just don't know how to communicate that, which has definitely led to some similar situations.
Yeah, I think that's a good point. I think that also points to the cultural competency. When you have someone who doesn't speak English and they're being talked to in English. I think cultural competency has to do with that. All right, I'm moving to number 8. LEP patient, limited English proficiency patient, arrived in the step-down unit, thoracic surgery. Hypertension in OR, and upon arrival to recovery room, 205/97. Patient with history of CVA in past month, no past medical history or medication list available. Anesthesia, unable to give proper report or orders for hypertension management due to lack of information. So what are some things that went wrong in this one?
Somebody said gathering history went wrong, in that scenario.
Also, the fact that they're in an operating room and they're having surgery puts them at higher risk for adverse events on its own. And there's also patient comprehension of how to take medication. I'm sorry, I misread that. Any others? Any other comments for this one?
Somebody said follow-up care probably did not go as planned.
Yeah. All right, I'm gonna go to the next slide. Okay, so now that we've seen situations where things can go wrong or that are of high risk, there's 3 key recommendations. One is require the presence of qualified interpreters for all patients who have limited English proficiency. Schedule this in advance when possible. The second one is provide access to translated materials in preferred languages. And the third one is use teach-back method to confirm patient understanding. The first 2, if you remember from the history of interpretation, fall under accreditation standards and national standards for a hospital. So providing access to interpreters, and then also providing written materials for folks. And I also want to give folks a chance if they want to share anything about their thoughts on these key recommendations, because I understand that it could be frustrating if your hospital you don't have access to these things in the first place, or they don't work how you want them to work, how they should work. So I'll give folks a couple seconds if you want to share anything about frustrations with that or experiences with that.
My understanding is that if you receive Medi-Cal or Medicare funds by law, because of the 1964 the Non-Discrimination Act,
Mhm.
that you have to provide language services, language access services through medical interpreters. And I feel like that's kind of the standard of care if you receive certain types of insurances or certain types of funds. Like I know here in New Mexico, Medicaid reimburses for interpreting services if your clinic or hospital uses Medicaid. I think it's more the accountability for either independent clinics or smaller clinics that don't have that financial need, right? That like, or some type of governing body that's making them have these interpreting services in place. Not to say that providers use them or nurses and staff, but I think that there is at least, you know, I try and tell patients like it's your legal right to have an interpreter, and you should be able to ask for them, especially in these bigger institutions that receive federal funds.
Yes, definitely. There's these requirements do exist, but there's a lot of hospitals that or healthcare institutions that don't necessarily follow them or don't follow them fully. I have experienced personally going to a medical appointment for myself and having a medical staff ask me to translate for another patient. Okay, so these are some best practices for clinicians for one-on-one interactions. And so the first one is assess patient language needs for medical information specifically at the start of appointment and request an interpreter when necessary. A focus group of 22 Spanish-speaking adults with limited English proficiency found that language discordant clinicians often overestimated patients' understanding of English. Also, it's important to consider regional variations in languages and important to use interpreter's translation instead of relying on your own. Communicating informally as a way to establish a rapport is encouraged, though. It's also important to record language preferences in medical record system and check for previously added information. Consider patient-centered interpretation practices. So a patient might have a preference between in-person and phone interpretation or the gender of the interpreter. Medical providers should avoid jargon and idioms when working with an interpreter. You should address patients directly and allow time for interpretation. And it's also really important to collaborate closely with interpreters. A cross-sectional study of communication practices during childbirth hospitalization showed that only 36% of clinicians documented using an interpreter. 2 out of 3 patients who spoke languages other than English had a cesarean section reported receiving information in English with no interpreter present.
Few
So a lot of
comments.
folks. Oh, yep, go ahead.
Few comments in the chat. So coming from an indie clinic background as well as larger repro, I feel like what I need as a worker is tools on how to advocate for money to be spent on language services. Next is, yes, we often tell patients that is their right and they don't have to pay an interpreter, but they have told me that the interpreter provides transportation as well and as a package deal in a more rural area. And then also want to identify that sometimes bilingual nurses are asked to do double duty as interpreter, which is just like getting unpaid labor out of nurses who happen to have language skills. And just want to echo all of those, especially the how to advocate for money for language services. We are also in the same boat of trying to get our workshops translated, and it is a lot of money. And also the double duty of bilingual nurses.
Yeah, that's very common. I think even outside of medical context to, the person who speaks a certain language to become the translator on top of the other work that they're doing for sure, and not being paid for it. Okay, so we're gonna get into some communal and systemic considerations. Okay, so implementing a systemic approach. So some things that can be done is you can start by assessing the current climate and culture around safety for diverse populations. Institutional buy-in for creating a welcoming environment for diverse patients must be achieved, and hospital leadership must also support and promote tools, resources, and key practices. It's also important to have tools needed to succeed available, such as interpretation services and databases that require language information. It's also important to give staff specific ways to promote a welcoming culture for diverse patients. Another important thing is strategic planning for short and long-term goals for creating a welcoming and safer environment for diverse populations. It's important to encourage and provide ongoing learning and training for staff. Creating advisory councils as a way to promote patient perspectives and to promote close collaboration with interpreters. It's also important to adapt current systems to identify medical errors with limited English proficiency. Improve reporting of medical errors for patients with limited English proficiency, make information readily accessible by linking databases, add fields that collect information about culture and language, and if an interpreter was used, and have open and regular communication about lessons learned regarding patient safety. So creating a culture shift within staff and how that looks to patients. Be aware of risks some patients with limited English may face, such as deportation. So, for example, collecting immigration status information can have catastrophic outcomes for patients and their families. Only collect information that is necessary and will be used by your institution. Collecting immigration status create distrust from patients and their discontinuation of medical services for themselves, their children, and their families. And finally, it's important to train staff to identify and document safety events. So it's about like getting comfortable with identifying those and reporting them as frontline staff as well. Create systemic and cultural messaging that empowers staff, in particular those on the front lines, to report and record medical errors, as well as patient safety events. Routinely monitor patient safety reports for patients who speak languages other than English. implement routine-based institution-wide practices to analyze patient safety findings, and focus on root causes of patient safety events, and develop strategies to problem solve and prevent errors for patient safety. Some questions that you can ask are, how does this goal align with our mission, with accreditation standards, and existing systemic practices and values of the institution? And these are some ways to address preventable medical errors. Provide dedicated interpreter, telephone or in person, have translated materials in several languages relevant to your region. Provide ongoing cultural competency training for interpreters and staff. Provide ongoing training for staff and clinicians regarding how to work with interpreters, the value of interpreters, and the need for cultural competence and providing patient-centered care. Employ professionally trained multilingual staff to bridge gaps that may not be fulfilled by interpreter services, and of course, paying them for those services. Establish requirements around timely coordination interpretation services. Establish a healthcare team model that includes interpreters as an important component of the healthcare team. And promote collaboration between departments to dispel power dynamics and hierarchy issues between healthcare workers, such as between interpreters, clinicians, and staff. And a couple others that could be helpful are to train staff to recognize and address medical errors, adverse events, near misses and close calls, never events, and be able to report them because of, like the previous slide mentioned, like there's issues with hierarchy sometimes, or somebody might think someone like the doctor might be reporting it, but it's important for everyone who's in the team to be comfortable with identifying the scenarios and reporting them. It's also important to establish protocols for clinicians to communicate errors with patients and significant others. If done sensitively, this can build trust and provide training and guidelines that are culturally responsive and geared to patients who speak languages other than English. All right, so we are towards the end of the presentation. So based on your answer from before, folks don't want to do breakout rooms. So we're gonna do it in the chat. And I'm gonna read this clinical scenario. So again, your questions and recommendations sheet has this on there. And the questions that we will be asking are also on there. All right, so scenario 1, a 29-year-old patient who has been pregnant once and has 0 children, who is undergoing labor induction for decreased fetal movement, develops non-reassuring fetal heart rate tracing in the 2nd stage of labor. The patient is Black and has documented Cape Verdean Creole language preference. A phone interpreter has been called intermittently during her labor, though not continuously throughout the 2nd stage. The team experiences delays in counseling and consenting the patient for cesarean birth due to more than 20-minute wait for a Cape Verdean Creole interpreter. Neither a virtual interpreter, tablet, nor an in-person interpreter is available. The patient's husband offers to interpret in the operating room. The team is faced with balancing the use of an ad hoc interpreter with limited availability of qualified interpreter services overnight in the labor and delivery department. The patient expresses dissatisfaction with her care team because she does not fully understand her birth experience. Do folks want to share what they notice and or perhaps what could have been done to prevent those things that went wrong?
In my experience, if you know that somebody that you're taking care of, speaks a language that's a little more niche or might be a little bit harder to find an interpreter for, which I've run into a couple of times now, I would try to get as much like explained and out in the open when they got there, because this was an induction, so it's scheduled. Um, I would try my best to schedule an interpreter to be there. Sometimes we do that if we have scheduled C-sections, we schedule an in-person interpreter because having an iPad on during surgery is really hard. And I think it gets in the way a lot of times of the patient understanding what's happening. But I think it's one of those things where if you're able to get an interpreter, you just explain as much as you can what could happen, what might happen, what is happening while you have the interpreter.
Yeah, and that's great also that they're being scheduled in advance. I think that that is one of the really important things that can be done to do it preemptively. Any other stuff in the chat or folks who want to come off mute?
I think sometimes it's with these kind of longer procedures or longer patient experiences, we tend to do the kind of cut up interpreting where, we'll be like, okay, we'll call you basically when we as the providers need to talk to you. And I think it's really important to sometimes what we've done during inductions is have like every 30 minutes we call the interpreter and we make a plan with the interpreter that they're going to be available every 15 minutes. And sometimes it's just a check-in with the patient of, hey, do you have any questions? Because as somebody who speaks English and can readily communicate with a provider, they're gonna, speak up, raise their hand, say, hey, I need this or I need that. And when you don't feel like you can do that, I think that really hinders your care. So even if you're not gonna have the interpreter on for the like full time, which I know most places will not want that, having like a every 15-minute check-in for somebody who's going through either an induction or a procedure, then that's helpful in having that interpreter always available, and not depending on kind of when the provider needs to talk to the patient.
That's a really good point. That sounds like patient-centered care.
Can I ask about other folks' experiences of something that's not really like institutionally sanctioned or like even patient-centered, but the use of AI in interpretation settings? I've seen more and more that folks are reaching for that, but I'm not sure that I feel super comfortable with it.
I've definitely witnessed that. I don't know. I think there are also some misperceptions of like AI being a more legitimate tool than other tools from some people's perspectives. But I've witnessed that as well.
We use I've seen it used a lot at some of the clinics that I've worked at. They basically rely on Google Translate. And so I've done a couple of research and basically Google Translate is not HIPAA compliant. There is a thing called Pocket Talk, which I think some of the Department of Health clinics in Massachusetts, maybe. I don't know. I'm not from there, so don't quote me. But from what I've seen in their reviews and on Reddit, they have used Pocket Talk, and that is supposed to be HIPAA compliant. So kind of with the AI version is like, the question is it HIPAA compliant or not? And I've seen patients bringing in the Google Translate because it's something that they feel comfortable with. that being said, I think sometimes it has covered, like during a procedure, we've used it if there wasn't like an interpreter available. And it's been helpful for having kind of that in the moment translation or interpreting. But I also feel very nervous about using it. And but yeah, I think it's used a lot more than we think. Probably not in hospitals because they have more access to paid interpreters and there is more of that standard of care.
I work at a smaller clinic, and I know that our front end staff is pretty liberal about its use of Google Translate, uh, especially I think it's in part because they see what they're doing, basically giving basic instructions, as less important in the patient encounter, which I mean, I'm not part of that, and I would disagree. But I do see patients who use Google Translate either with documents that have not been translated into their language, or during their encounter with the front end staff. And part of it seems like, oh, maybe it is patients feeling comfortable with that technology. Maybe it's also patients who feel like they can't get someone to speak the language that they speak, so it's what they're resorting to is using Google Translate, which doesn't feel super great.
Thank you so much for folks who asked that question and answered the question. I'm hearing that folks really need the tools and are making do, when they have to, which is definitely it makes sense, because you're in this situation where this person needs treatment. So yeah, that is understandable. Is there any stuff in the chat? All right, I'm gonna go to the next scenario. Or actually, just real quick, I want to just go over some of the things that went wrong here, which is obtaining informed consent, also patient comprehension of diagnosis, treatment plan, discharge instructions, preparing for tests and procedures, treatment complications, and surgical care, as well as follow-up care. And this is scenario 2. A 36-year-old patient who has been pregnant 3 times and has 1 child with abnormal bleeding due to leiomyomas is being treated with hormonal menstrual suppression. After counseling regarding options, she is sent home with instructions to take 5 milligrams norethindrone acetate once daily. The patient is primarily Spanish speaking, but there is no documentation in her record of whether her visit has been conducted with an interpreter or qualified bilingual staff. Her prescriptions are sent with instructions in English. At her follow-up visit, she reports that she has been taking 11 pills of norethindrone acetate daily because once means 11 in Spanish, or once would be how she read that, which means 11 in Spanish. So I'll start off with some high-risk patient safety scenarios that happened here, which is the one that we keep seeing, informed consent. The person wasn't able to be actively an active participant of their healthcare. And also gathering medical history and accurately. The patient didn't understand proper use of medications. Anything folks want to share about this scenario or anything that it reminds you of in your work?
I think that this case highlights that because we cannot imagine the number of ways that patients may misinterpret or be unable to understand what we take for granted, we cannot imagine that we can sort of mitigate the risk of just putting something in English.
Last thing was just the idea that Google is combing through my medical interactions is terrifying. As a professional, I would be mortified by the results of language differences. And here's some ones before. I'm not sure if you saw, but somebody said the public school system in Albuquerque uses the headset for interpreting too. Lots of different institutions are utilizing them.
Well, I'm glad to hear that people have different tools and also understand that some of these tools don't feel safe, especially nowadays. All right, so let's see what's next. All right, so that was supposed to be a breakout room, so we're not doing that. Okay, so just to summarize, some key takeaways are language justice is essential for equitable healthcare. Patients have the right to communicate, understand, be understood in their preferred language, and be active participants in their healthcare decisions. Linguicism creates significant health disparities. Lack of professional interpretation leads to medical errors. Untrained staff or significant others, or providers using their basic language to get by increases the risk of misdiagnosis, mistreatment, and preventable harm. Systemic barriers create poorer health outcomes for diverse patients. Patients with limited English proficiency experience longer hospital stays, higher rates of adverse events, and lower quality of care. Healthcare institutions must implement policies that prioritize language access, cultural competence, and a welcoming environment for diverse patients in line with legal requirements and accreditation standards. Best practices and institutional changes can improve patient safety. Providers should assess language needs at every visit, use professional interpreters, confirm patient understanding with teach-back method, and participate in systemic change made to support language justice. So in that sheet that you have, the one with questions and recommendations, at the very end is a resource list. And now I want to open it to any questions that folks might have. Feel free to drop it in the chat or unmute yourself.
I just want to share that in the hospital system that I work in, for our patient safety reporting mechanism, there's a section within that offers the option to identify whether bias or language barriers were part of the patient safety error. And if you work in a health system that has the opportunity to add that, I feel like it actually really enriches the sort of the mechanism for patient safety reporting.
Yeah, that's a great point. It also will move the culture in a different direction where those things are more top of mind for folks. Thank you.
So if you want to go back a few slides for the survey, and I'll go ahead and just introduce that, and then we'll give everybody their night back. Awesome. So we have a survey. It's also linked in the chat as well. I'll go ahead and drop that. We really value your feedback on how to grow our workshops, other things you might be interested in having a workshop on. Feel free to go to our website as well, and sign up for our newsletter because that's where we drop upcoming workshops and our social media. So I'll go ahead and drop our website, and then, yeah, fill out the survey. If you want a certificate of completion, go ahead and fill that out. That'll be emailed to you. The recording will be sent out as well, with the survey and resources that Pamela has provided for you all. So thank you so much. You also get a chance to be entered into a raffle for two $25 gift cards for filling out our survey. So thank you, everybody. If there's no further questions, feel free to fill out that survey either now or when the recording comes out. It'll probably take a few weeks for us to edit and do things like that, but it'll be sent. And thank you for the engagement, the participation, and have a great rest of your night or evening, afternoon, wherever you are.